Hi everyone, before we begin this episode, I've got a little favour to ask you. We'd love to hear a bit more about you and what you think of the Conversation Weekly. So we've launched a listener survey. It should just take a few minutes of your time, and we'd really appreciate it if you could fill it in. To do so, please click on the link in our show notes or on the link in the article that's associated with this podcast on The Conversation, if you're listening via our website. Okay, now on with the show. Hundreds of millions of people around the world experience chronic pain. That's pain which lasts longer than 3 months. In the past, doctors have relied on medication as a quick and easy solution. But since the opioid crisis in North America, doctors are re-evaluating what they prescribe and looking for new treatments. Today we're speaking with a pain management specialist about some of the new developments in pain treatment and why she thinks there's hope for patients with chronic pain. I'm Gemma Ware, and this is The Conversation Weekly, the world explained by experts. Telling this story for us today is Amanda Mascarelli, Senior Health and Medicine Editor at The Conversation in the US. Welcome to the show, Amanda.
Thanks so much for having me on.
So, Amanda, when we first talked about doing a story on chronic pain a couple of months back, you told me that you'd got interested in all of this because of something that's happened to your mum. Can you tell me what happened to her?
Yeah, so in early 2023, she had a total knee replacement on her left knee, and things were going well. But about 6 months later, she took a fall and broke her knee as well as her femur directly above the knee replacement. And she had 2 emergency surgeries and had a pretty risky prosthetic put in place. And then after a few months of things looking pretty good, she began to experience excruciating pain. And after numerous starts and stops, found out that the prosthetic had come loose and was the cause for the very severe pain she was experiencing. And she was referred to a well-known orthopedic surgeon who, after looking at her history, said, this is a very risky procedure that we would have to do. And unfortunately, I think that you might be better off just living with the pain. And I just couldn't accept that in this day and age, there wasn't something more that they could do for my mom to ease her pain and also repair her fracture.
And sadly, this is not actually that uncommon, is it, for somebody to be told that they've just got to live with the pain that they're suffering?
Not at all, unfortunately. While the numbers vary country to country, most studies put the number of patients with chronic pain around the world at 10% of the world's population. So this affects approximately 800 million people. And here in the US, the CDC estimates that about 20% of adults, more than about 50 million people, experience chronic pain. Of those, about 7% experience what's called high impact chronic pain, which means pain lasting longer than 3 months that results in substantial restriction of their daily activities.
And you must have seen this with your mum. Pain affects everything about your life. It can take a real mental toll on how you go about everything you do.
Absolutely. And in many cases, patients with chronic pain who go to the doctor for it have to convince their doctor that the pain really is that bad and that debilitating. So convincing their doctors that they need treatment can be like another layer of pain in itself for people suffering chronic pain. And even those whose doctors believe them will often say, as was the case with my mom, that, there's not much we can do, which is, again, just so disheartening.
So with all that in mind, Amanda, you, in your position as health and medicine editor, you tried to reach out and get some help for your mum. What did you do?
Yeah, in my position, I speak with professionals across all fields of health. And so I told my mom, there's got to be something more we can do. Let me do some research for you. So I began looking into what types of treatments might be out there for the sort of pain she was experiencing. And that's how I got put in touch with Dr. Rachael Rzasa Lynn. She is an anesthesiologist who has a subspecialty in pain medicine at the University of Colorado Anschutz Medical Campus here in the Denver area where I live. She works with patients every day and is up on the latest that's happening in the field of chronic pain, as well as new directions for pain management.
And Amanda, you've actually been speaking with Rachael for this episode of the podcast, and you've been getting a better idea of what options are really on the table for people suffering with chronic pain.
That's right. And when I reached out to her, we started by talking about how doctors measure and assess their patients' pain, which isn't as straightforward as it might seem.
I think everybody who's been to a hospital, at least in the United States within the past decade, is familiar with the rate your pain numerical scale. We're only asking about how severe it is. Pain is a really complex phenomenon that has a lot more pieces to it than just the severity. So a single numerical value saying the severity of pain really misses the impact that pain may be having on a patient's daily experience, daily life, their activities, their relationships, their ability to sleep, their happiness and overall satisfaction with their life. I think the most difficult thing about all pain, truly, but especially many forms of chronic pain, is you can't see it. There's no external validated way to see it. So we have newer methods for measuring pain that attempt to get at some of those more complex areas, but it's still a very incomplete science.
Rachael explained to me that there are actually 3 different biological processes that can result in pain. The one that's happening to most people when they experience acute pain is called nociceptive pain.
And that's pain that is due to tissue being injured or harmed in some way, which triggers the activation of nerves in that peripheral tissue. These nerves are electrical wires that send signals through the body, through the spinal cord, to the brain, where pain is ultimately perceived. But that's a really important step, is the perception of pain, because pain doesn't occur when people are unconscious. And pain involves the amplifying and diminishing of those electrical signals at multiple levels along the spinal cord and brain.
What this means is that not every type of injury, even to the same area of the body on the same patient, results in the same level of pain, because those signals can be turned up or tamped down.
But there are some disease processes where nerves themselves become injured and they start to send pain signals that don't reflect injury to any other tissues. They're actually reflective of injury to the nerves themselves, and that's called neuropathic pain. And then there's a third type of pain that was recently given the name nociplastic pain. And it's pain that occurs despite no injury to peripheral tissues or to nerve tissues, or pain that is experienced in excess severity or duration from what would be expected from the type of injury that might have occurred previously.
In many cases, Rachael says, chronic pain is a combination of 2 or even all 3 of these types of pain.
Back pain is a classic example of this. So when somebody has a disc herniation, when a disc, bulges out of its confines, it causes a lot of inflammation. And that right there is a source of nociceptive pain. But that disc material might push on an adjacent nerve, irritating it, causing direct nerve-generated pain, which is neuropathic. And if this pain goes on long enough, the spinal cord and the brain start to adapt to that constant barrage of signals from the back about pain, to the point where there may be some elements of that pain that are actually generated within the brain and the spinal cord even after that disc herniation has healed.
This is why finding the right treatment for a patient's chronic pain is often a long and difficult process. But doctors have many options for treating patients who are experiencing chronic pain.
For a lot of people with chronic pain, it's kind of a combination of those different, I call them tools in the toolbox. We tend to layer our pain approaches, starting with the things that are lowest risk and sort of escalating, risk to the patient from there. But again, it's a layering. We typically don't use, one therapy in isolation. We're trying to come at the pain from as many angles and approaches as we can at one time.
These tools include some methods that have been around for a long time, like physical therapy, surgeries, and medications. But there are also some new forms of treatment, many of which have been developed in the midst of the opioid crisis.
The opioid epidemic. It's the deadliest drug crisis in American history, killing about 90 Americans every day.
Overdoses up, emergency services overwhelmed, another family burying a loved one.
In the 1990s, the U.S. healthcare system saw a rapid increase in the overuse and abuse of opioids, drugs like hydrocodone, oxycodone, and morphine. According to the U.S. Centers for Disease Control and Prevention, between 1999 and 2021, approximately 645,000 Americans died from overdoses involving opioid use.
Opioids are incredibly effective to relieve pain, and it would be very difficult to do any of the surgeries we perform today without access to opioids to help manage pain after surgery. However, there's a lot of types of pain and a lot of situations in which opioids aren't necessary. And yet, over the past couple of decades, they were introduced a little too soon before other lower risk medications had been tried and failed. I think in response to the opioid crisis, we've tried to find more and more ways to target pain that don't rely on a drug that's going to affect a wide variety of organ systems, especially the brain and the respiratory centers that live within the brainstem.
One approach has been injections and advanced procedures based off of the idea of an injection.
So things like nerve ablation, where the nerve that feels a particular area of the body is deliberately anesthetized or numbed with a medication, and then potentially either ablated, which is where we gently heat that nerve to damage it such that it can no longer effectively send pain signals for a time, or stimulated, in which case we actually place a little electrical device alongside the nerve to change the type of signals flowing through that nerve. The latter is probably a more typical example of what people call neuromodulation. Most of the time, we're talking about devices that send different signals through the nerves or affect the way the nerves are sending signals and result in a reduction in pain. The most probably classic example of that at this point in time is spinal cord stimulation, which is a form of neuromodulation in which wires are placed underneath the bones of the back, but outside of the spinal cord and the spinal fluid. And they connect to a battery, much like a pacemaker battery, that delivers electrical signals to those nerves in the spinal cord in a way that scrambles the pain signals coming from a variety of different conditions and can be targeted to almost any area of the body.
Another new treatment called pain reprocessing therapy, or PRT, takes a behavioral approach to eliminating pain. Some of the groundbreaking research on this therapy is taking place right at Rachael's home institution, the University of Colorado Anschutz Medical Campus. Therapists guide patients in doing painful movements while helping them to reevaluate the sensations they experience. The goal of PRT is to help the patient perceive the pain signals being sent to their brain as less threatening so that their brain unlearns the pain.
We, for a long time, have known that behavioral approaches like cognitive behavioral therapy can help diminish pain in a variety of conditions. And for a long time, I would say the physical therapists, even more so perhaps than the psychologists, have been aware of the way that the brain truly controls pain, and that we often experience pain in excess of what should be there based on the physical processes or physical injuries, and that the only way to really begin to address that type of pain is from the brain down. And so that's what pain reprocessing therapy seeks to do, is really retrain the brain and start to rewire some of these nociplastic pathways that have developed that lead to pain that doesn't really have a good reason for being there.
That can be a tricky concept for people, I imagine, especially because there's a lot of sensitivity around the idea that pain is in your mind, or that pain isn't necessarily as severe as one might be expressing that it is. How do you talk about the idea of the brain being the source of those signals and how that differs from the idea that pain is in your mind?
It can be a really difficult conversation to have. A diagnosis of chronic pain can be very stigmatizing for patients. And once somebody is labeled as a patient with chronic pain, many of their pain complaints might get sort of blown off or overlooked by a lot of care providers that they come in contact with. So then returning to them and saying, no, your pain is real, but it's actually coming from inside your brain can be a little bit of a difficult nuance to draw. But that is the truth. The pain is real. The pain is occurring. It's just not coming from a tissue that necessarily can be fixed with a needle or a knife or a drug.
These new options on the table for patients with chronic pain may not have progressed as quickly as they have, if not for the opioid crisis. Still, Rachael notes that these new treatments don't eliminate the need for opioids altogether.
There are patients out there with chronic pain for whom opioids do truly provide benefit in terms of their pain relief and their quality of life. We've overcorrected a bit to the point where it can now be difficult for patients who've been on these opioid therapies for many years successfully to gain access to them. Some of that comes from guidelines that have been published by various specialty societies or other governmental organizations that have potentially been misinterpreted as stark lines in the sand of prescribing thresholds. In other situations, in an effort to reduce harm and curb overprescribing, states or other organizations have introduced limitations, again, in the form of guidelines or potentially even laws that severely restrict what we can prescribe to patients, the dose or the duration of that treatment.
Due to a slowdown in manufacturing opioids over the last several years, in some parts of the U.S., many patients are no longer able to access these drugs at all. A lot of researchers are also now looking seriously into new non-opioid pain medications, including cannabis.
Everybody is hurrying to try and identify new medications that treat pain without that risk of addiction and without the safety risk of overdose that we see with opioids. And a lot of focus in recent years has shifted towards procedural interventions.
The emergence of new treatments is cause for optimism. But still, the only way to determine the best course of treatment for a patient's chronic pain is through trial and error.
I think the holy grail of pain medicine is trying to figure out which patients with the same condition are going to respond to the same treatment, because we can have two people with very apparently similar osteoarthritis of the knee. X-rays look almost exactly the same, and yet their pain experience is completely different, and their response to treatments is completely different. One may do fine with physical therapy. Somebody else may do that, multiple medications, injections, and ultimately surgery, and potentially still have pain. And we don't yet know what the defining characteristics are of one patient versus another in terms of those outcomes. So that's my goal, and my number one hope for the future of pain medicine is that we have a better way of predicting who's going to respond to a particular treatment the first time.
Rachael also recognizes that when treating chronic pain, there are more factors at play than simply physical health.
When we talk about pain as a biopsychosocial phenomenon. So it involves biology. That's all the nerve processing we've talked about. But it's also very much affected by a patient's social situation as well as their psychological situation. And if we try to treat just one piece of those in isolation, rarely does it work as well as when we come at pain with a more holistic approach that addresses all those components.
That sounds incredibly complicated. Do you find that you're often working with an interdisciplinary team to address all of those angles of pain?
In an ideal state, yes. In reality, not as much as I think we should or I would like to, but that would be best practice for pain management, especially for patients with more complicated pain that's not responded to a wide variety of treatments.
Still, even in an ideal clinical setting, overcoming chronic pain nearly always takes time.
And I think that's the other piece of that approach to pain management is it can be frustrating for patients who've been suffering for a long time and want to feel better really quickly. A lot of our best approaches for chronic pain aren't necessarily a quick fix. Physical therapy takes time to retrain, behavioral patterns and strength patterns within the body. And same thing with behavioral approaches like CBT or pain reprocessing therapy. It takes time to retrain those behavioral pathways from the brain to the body.
And of course, all of these appointments with pain specialists, physical therapists, and psychologists can really add up in terms of both time and, in the U.S. healthcare system at least, money.
It does involve that interplay between nerves and inflammation and tissue injury and brain processing. And so in those cases, patients need to be working with a behavioral provider, doing some sort of PRT or CBT, and often that's not covered by insurance. Even when it is, there's often a copay associated that's not insignificant for many people. Same thing with physical therapy. A lot of common pain conditions can be greatly improved or relieved by targeted physical therapy approaches, and yet that's really prohibitive for many patients, not only financially, but it takes time. Carving out time from one's schedule to go meet with a therapist and then making time on a regular basis to do the exercises and practice the techniques that you've been taught is not always possible for every patient.
But Rachael says that even with all the obstacles, she does have a lot of options to offer patients who come to her with chronic pain.
I do have all of these different types of treatments to draw from. And so it's pretty rare that a patient has exhausted every single one. But it does happen from time to time. And again, those are very disheartening and unsatisfying encounters, not only for the patient, but for the clinician on the other side of that conversation. We go into medicine and into this field in particular wanting to help people and relieve suffering. And when we've tried everything we can and nothing is working, it can be very frustrating. But it's fortunately very rare, and it's part of, I think, what motivates so many of us to constantly looking on the horizon for new technologies, new treatments, new applications of old treatments, so that we don't ever have to have that conversation with the patient.
Thanks so much for your time today, Rachael.
Thank you, Amanda, for a really interesting conversation. I have to ask now, was Rachael able to help you with your mum's situation?
So at the time I reached out to Rachael, I was really needing some perspective on my mom's overall situation and what avenues she might be able to go down. And Rachael was able to share with me some of the interesting new directions in pain management. As it turns out, my mom fortuitously found out about a team of specialists in orthopedic surgery at the Mayo Clinic in Phoenix who were able to take on her case. And they put in a really unique biologic compress, as it's called, that has been so far extremely successful. And her pain has been greatly reduced, and she seems to be on the road to recovery. But Rachael provided a voice of reason and hope at a time when both my mom and I greatly needed it.
I'm really glad to hear that. Thank you again, Amanda, for coming on the show. It's been great having you on.
My pleasure.
That's it for this week's episode. We'll put a link in the show notes to a print version of this interview that we published on theconversation.com, as well as a link to another story that Amanda worked on about pain reprocessing therapy. This episode was written and produced by Katie Flood, with production assistance from Mend Marawani. Sound design was by Eloise Stevens, and our theme music is by Nita Saal. Stephen Kahn is our global executive editor, and I'm Gemma Ware, the show's executive producer. You can connect with us on Instagram at theconversation.com or email us directly at podcast@theconversation.com. You can sign up for The Conversation's free daily newsletter by clicking on the link in our show notes. If you like what we do, please support our podcast and The Conversation more broadly by going to donate.theconversation.com. And please rate and review the show wherever you listen. It really does help us reach a wider audience. Thank you for listening.